I'd like to welcome everybody to tonight's presentation, an update on advances in the management of hepatocellular cancers, an interactive case-based discussion with Dr. Tanya Saab. Most of you know Tony from previous programs or from GI oncology in general. As you know, Tony is a professor of medicine at the Mayo Clinic College of Medicine and the program leader of GI oncology. And Tony, with that, I'm going to turn it over to you.
Thanks, Charles, and good to see everyone. So we'll go through a quick update about what's going on in HCC, and then we'll get to your cases. As you know, this is what we mostly rely on when thinking about how to best treat patients with HCC. So we use the modified Barcelona clinic staging and treatment that's modified by EASL. And essentially, all the stages, the early stages are either surgical or transplant. And we're mostly going to focus on advanced stage C, where we as oncologists see most of these patients also, although we're starting to see more and more some of these stage Bs coming earlier to us, depending on where you practice. And then, of course, the stage Ds are challenging. When you think about the evolution of first-line systemic therapy for HCC, we started many years ago, around 2007, with an agent called Sorafenib, a tyrosine kinase inhibitor that appeared to be better than placebo. The problem with this agent, of course, it was highly toxic and certainly very difficult to figure out the right dose for these patients, especially with liver dysfunction. Ultimately, 10 years later, Lenvatinib was shown to be non-inferior to Sorafenib and came to replace it, mostly not on the fact that it is a superior agent, but the toxicities, although there, appeared to be more manageable. And you all remember the disappointment with Nivolumab, showing no improvement versus Sorafenib in CheckMate 459, putting in question, the value of IO in HCC. And then, thankfully, IMbrave 150 came next, showing essentially an improvement in outcome versus Sorafenib. And we'll talk about these studies as we go through. So when we look at, immune checkpoint inhibitors, immune checkpoint inhibitor-based therapy in HCC, you can see that there's a heterogeneous responses to ICI-based therapies. So single agent PD-1, PD-L1 inhibitors give you a range of 7 to 20%, mostly around 10 to 15%. When you add the VEGF inhibitors, we see responses north of 30%. When adding a CTLA-4 inhibitor, 20 to 30%, and adding multi-kinase inhibitors, again, with Cabo about 10-15%. When Lenva, getting close to 30%. So how do we, taking the disappointments with single-agent PD-1 inhibitors, the thought is, how do we expand the benefits of immune therapy to more patients with HCC? So multiple things can be done. I'm not going to talk much about, local regional approaches, because these still need to have, some work done there. But the two most interesting are essentially anti-VEGF combinations, either with bevacizumab or tyrosine kinase inhibitors, and or CTLA-4 inhibitors, so going beyond PD-1 combos, and we'll talk about those as well with the Himalaya study. Try to put at the end, all this in perspective about, so what do we do now? So IMbrave 150 was a study with HCC. This is a study, first-line study that randomized patients to Atezo-Bev versus Sorafenib. And two co-primary endpoints, survival and progression-free survival. This study did mandate that patients undergo an EGD within 6 months prior to entry. And you have to see evidence of grade 1 or less varices to enter, or grade 2+ as long as they have been banded or acted upon, and then controlled before entry of study. Survival was positive, 19.2 months versus 13.4 months, and a hazard ratio of 0.66. Now, this 19.2 month is the highest overall survival be reported on a phase 3 study in HCC. And the hazard ratio is pretty interesting. I mean, you can see that a little bit more than a third of the patients were still alive beyond 2 years, going into 3 years. When we look at the PFS again numerically was better at the median and statistically significant. And the hazard ratio of 0.65. And you look again at the tail end of the curve, you can see that about 20% of the patients remain progression-free and alive beyond 2 years. And the response rate on the study was actually interesting. The response rate that was reported on RECIST 1.1 was 30%. So a third of the patients had a response with atezo-bev versus 11% on sorafenib. I think what's most interesting is, I mean, this is a disease where with most agents we've used before these combinations, seeing a response was actually like seeing a unicorn. Lo and behold, seeing a complete response. And a complete responders were 8% of the patients. If you use the modified RECIST, about 12%. So quite a large number of patients. And I think one can argue that our clinical experience with this appeared to be similar to what we see on the study. And when you look at the follow-up systemic therapy on the study, there's certainly a third of the patients received tyrosine kinase inhibitors post-atezo-bev, and about a quarter of the patients that failed sorafenib ended up on immunotherapy. The toxicity was more favorable to atezo-bev versus sorafenib. As you can see, other than the toxicities that would be typically related to IREs or VEGF, everything else did favor significantly atezo-bev. But I think most importantly, when we look at the patient's reported outcomes, so the quality of life, it appears to be quite improved with atezo-bev versus sorafenib at the median of 11.2 months versus 3.6 months with sorafenib. One thing that's interesting, if you look at all the numbers with sorafenib, PFS, deterioration-free rate, they look very similar to what you've seen with SHARP. The one interesting piece is that the survival with sorafenib continued to go up, mostly because of follow-up therapy, so second and third line therapy. So sorafenib's survival is about now 13 to 14 months versus 10 months in the original SHARP study. And most of this has to do with, again, follow-up therapy. Another study that was presented at ASCO GI, Himalaya, and this study essentially was an open label, multi-center global phase 3 study and looked at essentially patients with Child's POA, so similar to the other studies, performance stats 0 and 1. The one thing that's different about the study is that they excluded main portal vein thrombosis. We'll get back to that point because that's an important point here. Patients were randomized to what they call the STRIDE regimen, which is tremelimumab 300 with durvalumab 1500, durva, sorafenib, and then there was a T75 plus D that was closed because of the lack of interesting activity. And the primary endpoint was essentially T300 plus D, so STRIDE, looking at overall survival superiority for the combo versus sorafenib. And then there was a non-inferiority, the design in this, looking at durva single agent versus sorafenib, and then looking at potential superiority. Now, the one caveat, and it's important to keep that in mind as you understand, try to understand and put the study in perspective, is that patients with main trunk thrombosis, so VP4, were excluded. Now, why is this important? This is important because those were included in all the other studies. This group of patients tend to actually have less varices, less risk of bleeding, and is a better prognostic group. So keep that in mind because that complicates a little bit how we interpret this study. The progression-free survival on this study was negative, meaning STRIDE did not improve PFS over sorafenib. So this was negative. The hazard ratios was 0.9, and you can barely see a little tail at the end. Now, the primary objective of the study, overall survival, was positive, but I would note also that the hazard ratio was 0.78, so almost 0.8, which is borderline uninteresting. And so there is a little bit of a tail at the end, as you can see, although the curves seem to be a little bit narrow at the beginning. So overall, it met its primary endpoint. It was statistically significant. Clinically, the delta is meaningful, but the hazard ratio is borderline interesting. So this was a positive study in that sense. And when looking at Durva versus Sorafenib, which I find actually this more interesting because, you know, with the Nivo versus Sorafenib, which looks pretty similar, but it was a superiority study, the non-inferiority margin here was met. And we'll see how the FDA, you know, reviews this and whether they will allow durvalumab to be one option. And you can think about those patients, perhaps, you know, with child's PUB score or more challenged, maybe, you know, good candidates for durvalumab. Response rate was in the 20%. Again, with Durva, interestingly, it was very close, about 17%. And so about 3% of the patients on the STRIDE had a complete response. And the disease control rate was 60%. So a bit lower than what we've seen with Atezo-Bev, although again, you know, cross-study comparisons are always tricky. Cosmic 312, another study with cabozantinib plus minus atezolizumab versus sorafenib. The study was primarily, this Cosmic 312 was primarily powered to look at cabo-atezo versus sorafenib, two co-primary endpoints, PFS and OS, and a secondary endpoint of PFS for cabo versus sorafenib and survival in others. The study met only one of its primary endpoints, PFS, unfortunately negative for OS. And I'll show you some of this data. This is essentially the final analysis on the primary endpoint of progression-free survival. You can see that the PFS is a little bit better, and it has a ratio of 0.63, although the follow-up is not long enough at this point of time. So at least the hazard ratio may move. I mean, the medians are going to be where they are, but the hazard ratio may change with time, probably less interesting with time. When we look at the overall survival, not much of a difference between cabo-atezo versus sorafenib, 15.4 and 15.5 months. Now, this is pretty high for sorafenib. As I said, you know, when we look at study, it ranges between 13 to 15 months now, primarily depending on follow-up therapy. But unfortunately, this study was negative on the overall survival and a hazard ratio of 0.9. So when we look at all these studies, so IMbrave 150 and Himalaya specifically, and a little bit of Cosmic 312, we can see essentially, and again, cross-study comparisons are always, you know, tricky and certainly not scientific. But it's important to see that sorafenib across all these studies maintains relatively relative activity that's similar across arms, maybe a little bit more on the survival component in the Cosmic 312. And you can see the survival here in patients that went on IMbrave 150 with Atezo-Bev, 19.2 months, hazard ratio 0.66, STRIDE 16.4, hazard ratio 0.78. And then the median PFS was superior with IMbrave 150, but was actually negative for Himalaya. In fact, the median was probably a little bit worse with STRIDE. The response rate was high with IMbrave 150, or relatively high, I should say. I mean, you know, this is a good response rate for HCC, but hopefully we can do better than this in the future. Moderate for Himalaya, and you know, not that impressive with the TKI plus atezo. Difficult to explain why. The disease control rate again was higher with the VEGF plus atezo, same for cabo, and less so with the STRIDE. Now, when we look at the toxicities, very similar across all the studies. The one thing that's of interest, of course, is all grades bleeding. And what you can see here is very interesting. So when you look at the Atezo-Bev, you know, a quarter of the patients had some bleeding, but the severe bleedings were in 6% of the patients. When you look at the Himalaya study, the STRIDE, 2% had all grade bleedings and 0.5. Now, if you just compare those, it looks certainly more favorable for STRIDE. But when you look at the Sorafenib arm, you can see that when what Himalaya did is selecting out those patients with main trunk thrombosis, so VP4, and you can see that with Sorafenib, the risk of bleeding is pretty significant, and we know that from clinic. It becomes relatively insignificant on the Himalaya study because of the exclusion of the VP4 patients. So I think that's important to put all these things in perspective as we think about what do we do in clinic today. And we have a bunch of TKIs that were looked at in clinical trials across multiple studies, from Celestial to Resource to REACH2, through phase 3 studies. REACH2 is a monoclonal antibody ramucirumab. And these agents, cabozantinib and regorafenib, both showed improvement in outcomes versus placebo. And ramucirumab, only in patients with alpha-fetoprotein more equal than 400, did it improve versus placebo. And you see the survivals are all within the same range. The hazard ratios at least are all in the same range. In Pembrolizumab in second line was also looked at in HCC versus placebo, and was negative in the US study. The results of the China-only study with Pembro versus placebo actually were more favorable. And and when analyzing the data from both studies, and this is going back to the FDA, what became clear is that there's probably a little bit of an improvement with Pembrolizumab versus placebo. And now it's statistically significant when you combine the two studies. And so we'll see how the FDA looks at that. Since Nivolumab was actually pulled out of the market, Pembrolizumab remains on life support until we get the final determination. But when we look at Rego and Cabo and RAM, you can see the hazard ratios and Pembro are all in the same range for survival. But when it comes to PFS, PFS seems to be more favorable for the TKIs or RAM versus Pembro. In other words, what's happening here is that, those TKIs most likely appear to help most patients exposed to one a little bit, whereby those that receive Pembro, 10 to 20% will have a meaningful outcome. The rest don't actually appear to respond well to the treatment. So what do we do now with HCC in first line? So if a patient with advanced HCC first line has a contraindication to IO therapy, Lenvatinib or Sorafenib, so say patient with transplant or patient with severe autoimmune disease. On the other hand, the majority of patients with Child-Pugh-A and Child-Pugh-B7, those patients, atezo-bev will remain essentially the primary treatment option for those patients. Now I see patients with the risk for severe bleeding, and I give a caveat to that, because those patients actually are typically or have typically worse Child-Pugh score. They're typically 7+, or those that have actually main portal vein thrombosis, which were excluded from the Himalaya study. But still, theoretically, those are the patients when they have the risk of severe bleeding, their varices are not taken care of. These are the patients that may benefit from the STRIDE regimen. And, I would argue that for those patients with Child-Pugh-B7 and performance status that is borderline, that we'll see what the FDA is going to look at the durvalumab data, hopefully favorably. Durvalumab, may be that option for those patients in the first line. Now, what is still on the table is LEAP-002, first line Lenvatinib plus Pembrolizumab versus Lenvatinib. This study completed, however, has not read out yet. So the concern, of course, when studies take a longer time than usual to read out, is that the control arm is doing much better than predicted. So we'll see. It'll be interesting to see the results of this study. The other study, CheckMate and IDW, is looking at essentially high dose Ipi plus Nivo versus Sorafenib or Lenvatinib. This study is still accruing, so it's going to be a while before we see those results. So what do we do now with second line patients? We published this systemic network meta-analysis that essentially showed that regorafenib or cabozantinib would be preferred in the second line over other regimens. So in summary, I'd say atezo-bev is and remains the primary current standard of care for first-line advanced HCC. Patients who may be at risk for severe bleeding, and and this is uncontrolled and severe bleeding, may benefit from STRIVE. Although, again, given that they excluded many of those patients, one would put a question mark on this and would ask the question, can we just get away with durvalumab in some of these patients without having to add tremi? All patients who are not eligible for immune therapy, as we said, would be considered for a TKI. Now, second line options really depend on first line. Most of the data we have is actually in the setting of sorafenib. We don't have much data post IO, but overall, the data favors cabozantinib or regorafenib. I mean, you could consider potentially lenvatinib or sorafenib, and then maybe ramucirumab. I'm not sure. It has a good role, especially post bevacizumab. Child-Pugh score of B remain a challenge. I'd say a B7 with a good performance status could still be treated as an A, but cautiously. And future directions, include sequencing questions. How do we move systemic therapies into earlier stages and neoadjuvant strategies? And a lot of these strategies are being done. All right, I'm gonna stop here and see if there are any questions before we move to the cases. Okay. All right, so we're going to move to the first case. Who has this case?
This is a patient I saw recently on service, 50-year-old male with good performance status. He has a history of Hep C cirrhosis. The Hep C has been treated in the past. He has HIV, he's on antiretrovirals with suppressed viral loads, hypertension that's not really well controlled, and he has a history of variceal bleeding. He comes in with abdominal pain, basically found to have metastatic HCC. His AFP is 300, and he's Child's A, and is motivated to pursue treatment. So, given his comorbidities, I'm curious, how you would approach his first-line treatment.
So his HIV appears to be well controlled, correct?
Yes.
Would you consider this patient immunosuppressed, probably adequately controlled?
Right, probably not.
Okay. So no significant worries from IO. The variceal bleeding, is that controlled?
Yes, I mean, it's banded and not active.
Banded. Okay. And young patient, and the Child-Pugh score, would you say it's an A?
Yeah, A. Like
an A. Oh yeah, I'm sorry, you had it here. Yes, it's an A. So Child-Pugh score of A, variceal bleed that's under control, none immunocompromised, as many of these HIV patients, now are pretty well controlled with adequate heart therapy. This is a patient I would consider, atezo-bev as one option. There is a little risk, but and mostly, the risk of bleeding is a little bit higher. But since this is well controlled, this fits the criteria of acceptable risk. So and Child-Pugh score, I mean, this is a patient that can have a really good response with atezolizumab and bevacizumab. The alternative would be the STRIDE regimen, with theoretically a lesser risk of bleeding, although, as I said, they excluded the patients that are at highest risk for bleeding. And so we really don't know how that fares out. But my preference would remain atezo-bev for this patient.
Does the AFP level change? I mean, your opinion, if it were higher, for example, would that change anything in this case?
No, although the AFP being less than 400 is a good prognostic factor. So,
right.
so in that sense, and it doesn't really change much because most of these regimens don't appear to care much about alpha fetoprotein level, unlike ramucirumab. Yeah, so it doesn't really change much.
Got it. Okay, thank you so much.
Yeah, and I'd be, I'd very closely monitor this patient in the first 2-3 months. But beyond that, hopefully cruise control. Most of the toxicities, especially the ones that are most concerning, occur in the first 2 to 3 months.
Thank you.
All right, thank you.
So I have a strange case because initially the referral of the patient was done by radiation oncology, who jumped and irradiated a large liver lesion, which was within itself with several areas with hyperactivity. And after the patient received radiation, the patient was referred to me at a distinguished institution. The diagnosis by a small liver biopsy read as a secondary liver mets from possible GI cancer, either colon or pancreatic. So at that time, I gave the patient 2 months of treatment with FOLFIRINOX that did absolutely nothing with progression of the lesions. Interestingly, he was alpha-fetoprotein negative. At that time, because the patient developed severe hyponatremia with the sodium as low as 119 without freezing, I put him in the hospital, and while getting hypertonic saline, I repeated both the MRI and a secondary liver biopsy at a different institution. And the result read was a primary hepatocarcinoma. At that time, I switched the patient to Pembrolizumab and Avastin, and I treated him for another 4 months, but didn't truly do well. At the very end, the patient developed multiple lung metastases, and both the patient and the family withdrew the care. Patient also had severe alcoholic cirrhosis, and I had to do volume paracentesis every 5 to 6 days, 6 to 7 liters at a time. Question is, was I right picking up this regimen, or would have been maybe another one to be offered at that time?
I think you gave the patient the best shot at goal that you could possibly give him. The problem is, you're starting with a patient that's very sick, has ascites, Child-Pugh, so borderline where you would actually go more aggressive. The prognosis from the get-go was relatively poor. And so in many sense, again, relatively young patient, I think Atezo-Bev is a very reasonable, option to start with. You're going a little bit outside specifically where the patients that were included in the study, but most patients we see in clinic, like you do, are actually a little bit in that gray zone. And so I would have done the same if the wish was to treat. This is your best shot for a response. Everything else produces very little response, including the STRIDE regimen. I don't think the STRIDE regimen would have any advantage here for the patient. In fact, perhaps even less so of a response. So I actually would have done the same.
Thank you.
Yeah, just an unfortunate case. Okay, thank you. All right, case number 3, please.
Hi, thank you, Dr. Saab. So this is my so this is my patient with very interesting history, right? So he's 78 years old. He has hypertension, has actually diabetes. I think it's right hypertension here, but pretty severe hypertension. He was diagnosed with Child-A with lung mets, actually innumerable mets, in 2014. So I treated him with Sorafenib. Didn't do very well with hypertension and progressed eventually. And then enrolled him in a clinical trial, did exceptionally well for like 4 years. Right? And then eventually progressed, right? And then I tried him on Cabo, tried him on Nivo. Well, actually did well with Nivo, about a year. And then on Lenvatinib. So he's ECOG is 1 and he's still child A, but he's not progressed. It's been many years. So he really, doesn't want IV therapy. He lives like really far. I mean, he used to live very close by, but he just recently moved. So he doesn't want any IV therapy. So I thought I'm running out of options. I guess if I could convince him for IV therapy, what would you recommend? Or do you have any oral therapies to offer?
Well, the only oral therapy that's left is regorafenib, and I'm not sure, how much mileage you're going to get out of it. If you can convince the patient for IV therapy, I think that's his best bet. And the one interesting aspect of this is that you're telling me patient had a really good response with Nivo, which went for a while. That's a good predictor for patients who may actually respond for dual IO therapy. And maybe even Atezo-Bev. But dual IO like Ipilimumab, which is approved in the refractory setting. And based, this is looking at data from outside HCC, although there is some emerging data in HCC, just mostly case series. But if you look at lung cancer, melanoma, I mean, those are the patients who have initially good response to PD-1 inhibitor or PD-L1 inhibitor. They actually could, after you skip one line of therapy, could benefit from being rechallenged with IO/IO CTLA-4 plus. So Ipilimumab could be a good option. I would not use the approved regimen, meaning the high dose Ipi with Nivo. I would use, the low dose Ipi with higher dose of Nivo, the one we use typically in colon cancer, as one option. If the patient still doesn't want IV, you could give regorafenib a shot. I mean, there are some patients who do fairly well. Just use caution with a dosing strategy, similar to colorectal cancer at 80, 120, 160. But that would be the other option.
All right, cool. Thank you so much, Dr. Saab. This is super helpful. Thank you.
Of course. Thank you.
Listening to the other cases. So I have a gentleman in his 60s with liver cirrhosis, well compensated, who was treated with chemo embolization, I think, 2 or 3 times. And then I started him on Avastin and Atezo. And on Atezo and Avastin, his AFP went as high as 3,000. Scans were kind of sort of indeterminate, but most likely progression. So did not look like pseudo progression. However, and in the setting of rising tumor marker dramatically, I changed him to ramucirumab. And on ramucirumab, his tumor marker literally normalized after 2 treatments, which leads me to believe that he probably responded to immunotherapy as if this was a delayed response.
How long after Atezo-Bev did you start the RAM?
I would say maybe 3 weeks later or so.
And how long was the exposure to Atezo-Bev?
Only 3 months.
Yeah, you may have caught the tail end of the response with Atezo-Bev.
Yeah. So on ramucirumab, however, his tumor marker normalized, and then his scan is super stable to the point where now he has just 2 small areas that are, still likely cancerous but stable. So I refer him to the surgical team, thinking that maybe we can just resect those 2 active liver lesions. And in the end, the patient didn't want to have surgery. He said, I would rather do watchful waiting, which we did. And on watchful waiting, now he's 6 months out on no treatment with stable scans. Those 2 areas that were his target lesions are still stable, and tumor marker is normalized. So I've seen enough, cases to not be delusional. And what I'm thinking of, what would I do when his cancer actually will grow again? Because I feel like I will have to make a decision on which regimen actually helped him. So I was curious about how you would think of this case.
Oh, that's an incredibly interesting and challenging case. You know, the one way I would approach this is probably he's still on ramucirumab, right?
No, he's on nothing. He's on
He's on
watchful
nothing.
Yeah.
Yeah, you know, I'm a little nervous thinking that this is just a RAM response. I personally never seen a
Right.
ramucirumab response to that level, although, you know, that doesn't mean it doesn't happen.
Right.
So one thing you could do is you re-challenge the patient with RAM. If and when the patient progresses, and very quickly introduce, you know, IO. I wonder if, you know, RAM is I think has a little bit of an edge over Avastin as a single agent.
Right.
Avastin single agent, you know, didn't appear to have much activity across HCC and gastric cancer, whereby RAM has. So there may be a slight advantage for RAM. So I'd say, you know, RAM plus your PD-1/PD-L1 of choice that you could add. I wouldn't start with the combo. I would start with RAM and see if that settles things. If not, you know, you may again have 3 weeks. You still have enough atezo in the system, you know, to actually synergize with RAM. And the response is pretty remarkable, and you know, is reminiscent of a combo response rather than a single agent. So when progressing, do RAM, and then you know, add atezo or whatever else.
Right. Yeah, that is how I'm also thinking of the case.
Yeah.
I usually have a pretty low threshold to cause pseudo progression on immunotherapy, and especially in liver cancer. But the tumor marker just took off. The patient was anxious, and I was, you know, concerned too that he was not responding.
Oh, you did the right thing. I probably would have done the same. I just, you know, you know, the fact that you saw that response so dramatic after a bump, you know, just tells you that there may be a different level of synergism there.
Right. Yeah. Yeah. Thank you.
Cool case. Thank you.
Yeah.